Good day, and welcome to the fourth sequence of cardiology and critical care for the COVID-19 patient. Remember, you are not actually attending a full EKG course. We're just looking at those rhythms that are concerning for us in the critical care unit. And if you wish to have more information, you should take a full dysrhythmia course. And so to begin, yesterday when we ended off, we talked about the salient points so far. To remind ourselves that persistent tachycardia is always a warning sign. Always pay attention. Don't just chart it, don't just look at it. Always investigate it. Is it because of pain, agitation, high fever, or is it compensatory for tissue hypoxia? And new data that is coming to the forefront says that many of our critically ill COVID patients do not actually present with tachycardia when they're hypoxic. Oy! So what are we going to do? We're still going to pay attention, and we're going to be aware that hypoxia should be our critical driving issue in these patients. More about that later. Remember that a rapid heart rate may limit ventricular filling, and therefore the amount of volume that fills the ventricle, and therefore the amount of volume that is ejected from the ventricle. Persistent tachycardia is always a cause for concern. Bradycardia with hypotension, and by the way, bradycardia with incidence of tissue hypoxia, which is metabolic acidosis, is always abnormal. So pay attention to that when you're evaluating your patients. So the other salient points so far are to remind ourselves that we have two major groups of electrical cells, electrical capability in the myocardium. The primary, secondary, and tertiary designed pacemaker cells, that would be sinus node, AV junction, Purkinje fiber. And then those cells are supposed to be in charge of the heart. They depolarize first in sequence and can actually engage the rest of the heart. However, non-pacemaker cells can take over if those cells are irritable, if electrolytes are imbalanced, if there's hypoxia, limited blood flow. Those non-pacemaker cells, and I mean designated pacemaker cells, can take over. Important to remember that atrial cells are potassium and calcium dependent for depolarization, and ventricular cells are sodium and potassium dependent for depolarization. Well, that makes sense then when we say atrial tachydysrhythmias respond to beta block, potassium block, and calcium block, or antagonists, for dysrhythmia. And ventricular tachydysrhythmias respond to potassium and sodium antagonists. So what that tells us is potassium channel antagonism works across all the fields. And the number one potassium channel antagonist that we give is amiodarone. Okay, so to continue on our pathway in understanding dysrhythmia with our patients, I'm going to again show this slide that we talked about in our prior scenes, that rate is either fast or slow, that every P should have a QRS, that the PR interval is always constant, and that the QRS width is narrow, which means less than 0.10 and absolutely less than 0.12. So we talked about narrow QRS tachycardia, wide QRS tachycardia, narrow QRS bradycardia, wide QRS bradycardia. We talked about that in our prior sequence, and now we're going to apply it in the dysrhythmias of our patients. Okay, so to begin, what we always have to consider is any rhythm that is associated with instability, meaning hypotension, hypoperfusion, alteration mental status, chest discomfort, ischemia on EKG, shortness of breath, and any evidence of pulmonary edema. These are all hemodynamic instabilities that first and foremost we must look at our cardiac rhythm in order to fully understand that presentation. Now remind ourselves that hypotension should always be accompanied with tachycardia, and hyperthermia should always be accompanied with tachycardia. And then we want to remind ourselves that precedes, tension pneumothorax, hypothermia, induced hypothermia, may cause significant bradycardia. So we're always going to consider that when we're evaluating our patients, and we're looking at whether their heart rate is rapid or slow. Now, for our intents and purposes, of course, tachycardia is anything above 100. Absolute requiring investigation is any heart rate greater than 115. So always be aware that what you might today accept as acceptable tachycardia is unacceptable in a critical patient. It's a sign of compensation, but we need to know what that compensation is for. Okay, so let's start first with bradydysrhythmias, slow rate, slower than 60. And of course, the first one that we think about is sinus bradycardia. And that can be a physiologic variant, not pathophysiologic, because the patient has a strong vagal tone or because they are an athlete in training. And common causes of bradycardia that we must be concerned about: hypothermia, hypothyroidism, jaundice, cholestatic jaundice, and raised in intracranial pressure, increased intracranial pressure. And also, of course, we might induce bradydysrhythmias by the administration of beta blockers, calcium channel blockers, digitalis. Even though we don't use digitalis much anymore, we will occasionally see it. And the intrinsic causes, which are acute ischemia and infarction of the sinus node. Typically, we see that in the presence of an inferior myocardial infarction or a lateral myocardial infarction. We're always going to expect to see some alteration, sinus node discharge related to that. We can also see that in chronic heart failure patients who have chronic degenerative changes that change the sinus node, fibrosis around the atrium, promote an exit block, or promote what we call the sick sinus syndrome, which depends on your degenerative changes, and the heart is fast and then slow and fast and slow, but not in coordination with breathing. Okay, so biggest causes of sinus bradycardia, and we are going to pay attention: hypoxia, hypovolemia, hypothermia, metabolic acidosis, potassium that is high, potassium that is low, glucose that is low. Very important. Everything low: low oxygen, low volume, low potassium, low glucose, low temperature, poor low thyroid. Very important. And then one high in the H's, two highs in the H's. First, a high hydrogen ion, which is the metabolic acid, so metabolic acidosis, and a high potassium, which is hyperkalemia. So those causes, all those H's. And then we move to the T's. Any toxins? Is the patient in cardiac tamponade? Do they have a tension pneumothorax? Is there coronary or pulmonary thrombosis? Or have they had trauma and they have hemorrhagic hypovolemia, or they have an increase in intracranial pressure? And then, of course, I add one big P, and that big P is Precedex, dexamethasone, which we use for sedation for our patients, reduction of anxiety without suppression of ventilatory drive. So let's remember the H's and the T's plus one P. Those can be causes for sinus bradycardia, and what you're going to see later may also be causes for PEA, may also be causes for asystole. So all you have to remember are those two columns for all those dysrhythms. Now, when we think about sinus bradycardia, remember the first thing we do is we take a look at the heart rate. The sinus node is in charge of the heart. It's firing at a rate less than 60, which means P to P interval equals R to R interval. Every P wave has a QRS and they all look the same. It's regular. The PR interval is 0.12 to 0.20, and we have a narrow QRS. Less than 0.10 is optimal, less than 0.12 is absolute. 0.12 is your hard stop. Anything wider could be problematic. So let's take a look at this 12-lead EKG. And what I want you to notice is you have your component of 3 leads, 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, but down below the single, let me try it this way. Whoops. The single most important strip, which is the rhythm strip on the 12-lead EKG. So what I would do with that rhythm strip is mark P1 to P2, and then march that along P2 to P3, P3 to P4, P4 to P5, and so on. And then actually see that the R to R interval equals the P to P interval. And then I calculate the rate. and this rate is somewhere around 50. So we actually have sinus node in charge of the heart, ventricles responding to every sinus node depolarization, PR interval is constant, and the rate is slow. That is sinus bradycardia. Sometimes we confuse sinus bradycardia with heart block. And so that's a really important concept for us to remember, that we go through the same methodology every single time we're checking a rhythm strip. Okay, so lots of symptoms that can occur with bradycardia, some of which we will see in critical patients and some of which are actually self-reported. So, of course, severe fatigue, very tired, don't have an adequate cardiac output because cardiac output is heart rate times stroke volume. Patient may have chest discomfort, chest pressure, chest pain. They may have mental status changes. They're confused. They can't really concentrate. And they often will complain of being dizzy, and not just difficulties when exercising, but when sitting up on the side of the bed, when standing to use the urinal or walking to the toilet, they will have some significant difficulties. They often are lightheaded. They have palpitation, short of breath, syncope, fainting or nearly fainting, and frequently because of this may be because of enhanced vagal tone, they may have diaphoresis, which is of course sweating. All right, so pretty clear to see. If you just visualize those P waves, they look very regular, they look quite the same, they have the same morphology, and P1 to P2 equals P2 to P3. Now this isn't a very long strip, and I would require something longer than that if I was making a diagnosis, but for us we're going to say P1 to P2 equals P2 to P3, and the P to P interval, which I now have validated, equals the R to R interval. The PR interval is constant, and the QRS is narrow. So we are now going to call that, yes, you're right, sinus bradycardia. Perfect, 100% on your test. Then we're going to move, because most of us know bradycardia pretty well, we're going to move to something that actually is quite problematic in critically ill patients and oftentimes does not get diagnosed, and that would be AV block. Now, AV block can present in three categories: type 1, type 2, which has two subsets, and type 3. AV block is a delay or interruption in the impulse conduction from the sinus node through the AV junction to the ventricles. So I want to remind you that the PR interval is a measurement of the time the AV junction holds the impulse before moving it forward into the ventricles. So what we're going to remind ourselves is whenever we have a delay in the conduction from the sinus node to the ventricles through the AV junction, whatever that delay is, we're going to consider that to be a heart block. And remember, three different categories. And so, as we discuss that, it becomes optimally and profoundly important for us to remember that we must always look at the PR interval. Now, you might remember from the prior segment that the PR interval is from the beginning of the P wave to the beginning of ventricular depolarization, whether it's an R or a Q. In this case, what you're seeing is a Q wave. So from the beginning of atrial depolarization, P wave, to the beginning of ventricular depolarization, which might be a Q wave or an R wave, we look at that time. That normal time is 0.12 to 0.20 seconds. So these are milliseconds. It's a short time, and it's really telling us about conduction through the AV junction and the bundle of His, the connector from the atria to the ventricle. And this is so incredibly important in terms of evaluation of patients. So, very simple, easy peasy, first degree AV block. It's the most common form of heart block. We frequently see it in response to medications, in response to myocardial infarction, particularly, again, looking at inferior or inferolateral or lateral myocardial infarctions. We can see type 1 heart block. That is a standard, reproducible, constant prolongation of the PR interval. So that means you have an atrial depolarization, but the AV junction actually is slow in the communication from AV junction to ventricle. It's slowed communication. It usually is a little bit higher in the AV junction rather than lower. It tends to be more ischemic rather than infarctive. And so it's a very important concept because sometimes we have patients who have chest pressure and all they have is type 1 heart block on their EKG. So we're going to pay attention to that. Looks just like sinus rhythm. Every P wave has a QRS, but the PR interval is delayed and constant. And it's really just about the delay between atria and ventricle through the AV junction and the bundle of His. So an absolutely standard prolongation in the PR interval. So 5 basic steps based on the rate of the underlying rhythm, just the heart rate, and of course more significantly the P to P interval and the R to R interval. And that rhythm is usually quite regular. Might have a little variability. Remember, 0.04 second variable is okay, it's acceptable. And by the way, you can see that I had a change in level of consciousness when I was making this slide. No matter how much editing one does, it's never enough. Just like preparation for a disaster. No matter how much you prepare, it's never enough. So, is there a P wave before each QRS in first degree AV block? Are the P waves upright and uniform? And I said, yes, yes. That's what you see on that downward vertical display. Yes, there's a P wave before each QRS, and yes, the P waves are upright and uniform. And the length of PR interval is the telling factor here, greater than 0.20 seconds, and the QRS complexes all look alike, and our QRS is less than 0.12, optimally less than 0.10. So this is all good. It's very straightforward. Everybody here knows how to evaluate that, or at least if you used to actually measure it yourself, you actually know how to evaluate it. Okay, so what are causes and signs and symptoms of first degree AV block? Causes can be healthy, often temporary, usually seen in the face of myocardial ischemia or infarct, and remember, related to the coronary vessel that supplies the inferior wall and the coronary vessel that supplies the lateral wall. And a lot of different medications can cause this problem. But one of the most important ones, one you are going to pay attention to, despite the fact that we no longer put strips on our strip chart, what you must pay attention to, particularly in COVID-19 patients, is one of the major reasons that you see prolongation of PR interval is the inflammation of the myocardium, which is common to see in COVID-19 patients, and that would be myocarditis. So we're going to use that PR interval. We're going to measure that every 4 to 6 hours with a strip outside of the room, running the strip, and actually documenting the PR interval. Now, most patients who have prolongation in conduction time through the AV junction don't have any symptoms. Sometimes they can be dizzy, sometimes they can have syncopal episodes. For us, that's going to be very hard for us to differentiate because A, people who have COVID-19 complain of dizziness. Now, is that because they have some myocarditis? That hasn't been fully vetted yet. So we're just going to remind ourselves that dizziness is something that first and foremost we're going to look at myocardial involvement. Okay, so this is a nice, very nice view of first degree AV block. We see that prolongation constantly of the PR interval. Okay, and again, we see that P1 to P2 is a nice standard. It meets the R to R interval, and we would have a longer strip making sure that P to P to P to P to P is constant, R to R to R to R to R is constant, PR to PR to PR to PR is constant, and the QRS is less than 0.12. So pretty straightforward. So then we move to type 1 block. Type 1 heart block. Okay, type 1 heart block. Sorry, we were already there. This is just a summary slide. It's really generally not clinically significant, but during COVID-19, it may be a presentation of myocarditis, and we see that prolongation of the PR interval. Just remember, we're going to monitor closely to detect progression to a higher level of block. And again, type 1 heart block may be caused by myocarditis, myocardial infarction, therapeutic intervention, beta blockers, or Precedex. So now we're going to move forward to second degree AV block. Second degree AV block, Mobitz type 1, Wenckebach. That's what we typically call it. Second degree, remember, has 2 categories. Mobitz type 1, where the conduction of impulse from atria to ventricle gets longer and longer and longer and until there's no longer a conduction. Now we call that a drop beat. The beat that gets dropped is the QRS, but the failure is in the AV junction. So what happens is as the AV junction depolarizes, it takes more time for it to repolarize and longer and longer and longer and then none. So normal, longer, 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 none. Normal, longer, 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 none. And that is the sign of Wenckebach. Wenckebach means your AV junction actually has a longer and longer delay in repolarization and therefore cannot accept another depolarization. Now, oftentimes, this can be physiologic, it can be related to increased vascular tone, and it can be wiped out by exercise and atropine. So this is a really important concept for us in terms of how we're looking at our patients. Now, second, another category of type 2 heart block is Mobitz type 2, which is no warning, AV junction conducts, 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 fails, conducts, 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 fails. So you have no warning of progressive PR prolongation, meaning AV junction's getting tired, 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 fails, tired, 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 fails. It's just conduct, 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 fail. So that P wave is sporadically not conducted. And when we're evaluating our patient, what we actually see is our PR interval is typically constant. So that's very important. The PR interval is constant. The P to P rate is constant. What's inconstant is the R to R interval. Very, very important. So oftentimes with patients who have type 1 AV block, Wenckebach, we just watch them. This still tends to be a higher level AV junctional failure. It tends to be ischemic and typically does not require pacing. However, with Mobitz type 2, it's a little lower in the conduction tree, a little closer down into the bundle of His, and oftentimes is related to infarction. And it's related most particularly to anterior infarction, and so it's actually supplied by the LAD, the left anterior descending coronary artery, that lower level in the bundle, the common bundle of His, and oftentimes will progress to complete heart block. So we might pace you in Mobitz type 2, especially if you are having frequency of non-conducted atrial depolarizations, non-conducted P waves. Okay, so now let's look at second degree AV block, okay? And what you can see is your first PR segment is short, the second one gets longer, the third longer still, and now you have a P wave that is not conducted into the ventricles. So what you have is P to P equals R to R. No, P to P does not equal R to R because you have very irregular ventricular response. And then you see that the P wave itself, P to P, P to P, P to P, P to P, absolutely regular. QRS, irregular. And PR segment prolongating until your AV junction just says, I cannot communicate that depolarization, and then you have what we call a dropped beat, meaning no QRS in response to the P wave. And you can see during that dropped beat, if you look just to your left of that, you'll see there's your P wave, and you'll see there's your T wave before that. So that requires a lot of attention. Sometimes people will say, oh, that's some kind of other abnormal wave. Nope, it's the P wave. It fell right on time. What we have is a problem with the conduction between atria and ventricle. Okay, so steps to identify this. Type 1 Wenckebach. Heart rate, atrial is unaffected, but the ventricular rate is slower than the atrial and it's irregular. The rhythm, atrial regular, ventricular irregular. And is there a P wave before each QRS? Yes, for all conducted beats, but then you find a P that doesn't have a QRS. Now, first and foremost, you must make sure that the P to P interval is constant and regular, because it could be a PAC that's not conducted. So we have to be P to P, P to P, P to P, R to R, R to R, R to R, PR to PR to PR to PR. Well, that doesn't seem so difficult to me. We just need to have a framework of how we're evaluating. So you can see that the PR interval is progressively prolonging and the QRS is not being conducted. So do all QRS complexes look alike in second degree AV block? Yes, generally. And the QRS width is less than optimally 0.10, but absolutely less than 0.12. Okay, very good. So, causes, signs, and symptoms of second degree Mobitz block. Causes: you might be healthy, probably have an inferior wall MI, rheumatic fever, medications like beta antagonists, calcium antagonists, potassium antagonists. If the patient has increased vagal stimulation, in the old days we didn't let patients who were cardiac patients make bowel movements because the strain to actually expulse their fecal material, that increased their vagal stimulation and could put them into complete heart block. So we were always very concerned about that. That was 100 years ago when dinosaurs walked the earth and when my pet was a Tyrannosaurus Rex. So really important today that we don't think that way any longer. It's really profound vagal stimulation, and we're just going to observe our patient. Oftentimes they're asymptomatic, sometimes lightheaded, sometimes hypotensive, and their symptoms might be more pronounced if the ventricular rate is slow. Okay, so risk and medical treatment, type 2 and type 1. Type 1 may progress to third degree heart block, and no treatment is necessary unless they're unstable, right? So we're always going to monitor progression, and if our patients are symptomatic, we may give atropine or epinephrine, and we may actually use temporary pacing. Okay, now to second degree Mobitz type 2, reminding ourselves that your junctional conduction from atria to ventricle through that AV node, that junctional conduction, stays constant until there's a failure. So one of the most important things to remember here is that you are looking at P to P intervals. P to P, so P1 to P2, constant. P2 to P3, constant. P3 to P4, constant. P4 to P5, constant. P5 to P6, constant. That's what you're seeing here. So your P to P interval is constant, but your R to R interval is not. It's irregular, and that's because you didn't conduct through the AV junction. Now, on that time that you did not conduct through the AV junction then repolarizes and accepts the next conduction with a normal PR interval. So what you're seeing here is a 2-to-1 Mobitz type 2. Okay, so the first P has a following QRS and a standard PR. Second P has a standard PR and a standard QRS. Third P, no QRS. Fourth P, no QRS. Fifth P, QRS. PR interval is constant, and not every beat is conducted. Not every atrial depolarization is conducted. Now that's very concerning. For me, this is concerning because this is prodrome for complete heart block when it appears in this way. Okay, so 5 steps to identify second degree AV block, Mobitz type 2. Atria is P to P interval, it stays right on time. Ventricular rate is irregular and it is not constant with the P. So atrial rate regular, ventricular rate irregular. There's a P wave before every QRS that's conducted for those conducted beats. But when you've missed your QRS, what you do is look backwards or to the left on your strip and find that P wave. And then make sure that P wave fired right on time, meaning P1 equals P2, P2 equals P3, P3 to P4, that those are all equal. And you have to look at the strip to make sure about that. And every beat that gets conducted has a similar PR segment, a PR interval. And all QRS complexes look alike. They are intermittently absent, and they are less than 0.12 seconds. Anything wider than 0.12 seconds, your patient's already in complete heart block and they have AV dissociation unless they had it before you saw this problem. Okay, so let's just finalize with this. When we're looking at second-degree AV block, if you're looking at the top, you can see I drew lines showing you your PR. So here's your PR. Then it gets longer, then it gets longer, and then you're non-conducted. And then short PR, longer, longer, non-conducted. P to P rate is constant. R to R rate is inconstant. Now let's look down at the second strip where I have again marked P to P rate is constant. R to R rate is inconstant. And what you're seeing here is a constant PR segment for every conducted beat. So you have to look at a rhythm strip for this because it's easy to make an assumption that this is Mobitz type 2 when it could actually be complete heart block. Okay, causes, signs, and symptoms of second-degree AV block, Mobitz type 2, right? Biggest cause, because it's lower in the conduction tree, right? Not at the top of the junction, but lower in the common bundle of His, is anterior wall myocardial infarction. Anterior wall is supplied by the left anterior descending coronary artery, but also the left main before it splits into the anterior and the circumflex around the side of the heart. That left main or LAD, if there's involvement there, we're going to suspect and evaluate patients for second-degree AV block Mobitz type 2. So severe coronary disease, anterior myocardial infarction are really the big issues. Post cardiac surgery, you might have edema around the AV junction, but that's not going to be our worry because you're not going to be taking care of post-op cardiac surgical patients no matter what. Okay, so signs and symptoms might be asymptomatic, but oftentimes they feel like they have palpitations, they can become hypotensive, lightheaded, short of breath, and they can have chest pressure because this puts a significant ischemic burden on the myocardium in the attempt to maintain cardiac output. And therapeutic intervention, okay, so again, what we might see that the patient is asymptomatic and we just might monitor them. But we actually try to have them on bed rest to reduce myocardial oxygen supply and demands. We may give oxygen therapy, although that's very controversial in today's world. But we're going to try to raise the heart rate. And we try to raise the heart rate by giving epinephrine. We might even consider isoproterenol. That is something we would use. And actually, if our patient is symptomatic, we will progress to permanent pacemaker therapy. All right, so last part of this session will be third-degree AV block, which is complete heart block. Obviously, the most serious type of heart block because your atrium and ventricles are dissociated, they're disconnected, they are not synchronous. Okay, that's very important. So what we actually want to remind ourselves about third-degree AV block, that our biggest concern is that the AV junction is failing and that you may have complete failure, which then will lead to asystole. So complete heart block is an emergency, okay? So the ventricular rate is usually quite slow because now the Purkinje fibers are firing at a rate of 30 to 40 beats per minute. Our atria is firing at a much faster rate. So P to P, P to P, P to P, P to P, constant. Now your R to R is also constant, but it's a completely different rate because the atria is depolarizing, the ventricle is depolarizing, but they are not connected to each other. That's why we call it this disassociation. So on EKG, PP is absolutely on time, but it is not conducted and is completely unrelated to the regular and slow idioventricular rhythm. Remember what idioventricular is? Escape from death. But we don't want our patients in this precarious position. So P to P is absolutely constant and consistent, but it is not related to the R to R. There's no correlation, only circumstantial, not real, no correlation between the P's and the QRS. And you can well imagine that this is a dastardly dysrhythm. So I wanted to draw the P to P interval. So look at your P to P. Second P is what we call buried in the T wave, and I only know that because I did my P to P measure, made a mark on the index card and moved it over and said, whoa, there's where my next P should have been, and it fell on the T. And then my next P, and then my next P, and so on. So, causes, either anterior or inferior infarct, ditch toxicity, surgical injury. Very common to see this in patients who are elderly, and particularly in patients who have 1 or 2 bundle branch blocks. The treatment is one thing only, and that's permanent pacing. They need a permanent pacemaker. So while you're waiting for a permanent pacemaker, of course, you will do transcutaneous pacing. And you need to be aware that atropine, epinephrine, isoprel, none of that's going to work here. You need to pace. You need to pace, and you need to do it soon before the patient is asystolic. Now, obviously, these patients lose consciousness. They don't have adequate cardiac output. They're profoundly hypotensive. They have some warning signs with diaphoresis and pallor, severe fatigue, and oftentimes chest pressure or shortness of breath. Okay, so 5 steps to identify third-degree AV block. Atrial rate is normal, usually 60 to 100, and ventricular rate is just based on what area of Purkinje fiber is firing. So it's usually very slow. It's much slower than what the atrial rate is. The rhythm tends to be very regular. So the ventricular rhythm is regular as well. It's just really slow. And when we look at our P relationship to the QRS, we might see something every once in a while that looks like it's correlated, but as we march across an EKG strip, we see it's just coincidental. P is not related to QRS. The length of the PR interval, there is no PR interval. Just remember, sometimes circumstantially, it looks like there's a relationship, but when you march it along a rhythm strip, you see that it is not. Okay, and the QRS complexes look alike, but they typically are wide. They are typically wider than normal. Now, if they fire in the low junction, they might be more narrow, but it will be a different looking QRS than what you're used to. And if they're firing from the Purkinje fiber, you'll be much wider. You'll be able to identify that that is idioventricular. Okay, very good. So we look at complete heart block, and what you're seeing here is a lot of PR segments. It would be easy for you to say, oh, look, P to P is constant, R to R is constant. They're not associated with each other. But look, I have a short PR and a long PR. Maybe this is type 1 Wenckebach. However, you do not have a progressive PR interval that then is followed by a dropped beat. You have PR intervals that really are not related. P to P to P to P is constant. R to R is constant. QRS is wide. You're in complete heart block. Now that's really important because misdiagnosis often leads to an asystolic arrest. Okay, so treatment. The problem here is you've got a significant reduction in cardiac output. That's why you have a change in mental status. You're hypotensive. You feel dizzy. You might faint. You might lose consciousness. You might progress to cardiac standstill. So our aim is, number 1, improve the ventricular rate. So we might use atropine. We might use epinephrine. We might use isoproterenol, maybe. But the best therapy. I'm only giving you those drugs while somebody is getting my pacing defibrillator so that I can put pads on you and transcutaneously pace. And I'm going to transcutaneously pace you until you get a permanent pacemaker. Now, you might transition from transcutaneous to intravenous or transvenous to permanent pacemaker. But I don't want to keep you on a transcutaneous pacemaker for long, right? Because that's uncomfortable for the patient. All right, very good.